Good morning, everyone. Welcome to this warm March morning for the 2022 Beverly Todd Towery lecture. I'm going to tell you a little bit about Dr. Towery, and then we'll move on to our speaker. We do have a hard stop at 9 o'clock, so let's make efficient use of our time and questions. Beverly Todd Towery is dear to us. He was born in Springfield, Illinois, and then he grew up in Southern Kentucky, attended Western Kentucky State College, where he received his bachelor's in 1936. He went to Vanderbilt, where he spent a lot of his time, and he studied there and graduated first in his class. He also spent time at the Mallory Institute in Boston. And then he went off to war in World War II, when fighting the Italians and the French, and he emerged the war a major. Once he was a civilian again, he went back to medicine, and he was a senior resident at Mass General Hospital, where he had the opportunity to work with Dr. Fuller Albright. And he continued to train. It was interesting. He trained for almost 20 years in pathology and honing his skills, so he ended back at a laboratory in Boston City Hospital working with Robert Williams. Then he went to Vanderbilt, and he was a Markle Scholar. He was the first chief of the newly established endocrine division. We retained him in 1956 as the chair of medicine, and he served there until 1970. He was known for teaching, and he loved teaching so much that in 1970, he asked to step down as the chair and go back to what he loved the most, which was bedside teaching. Unfortunately, a few years later, he became ill with an encephalitis from a virus and didn't fully recover. And so he ended up retiring earlier than he would be. His friends and family were so sad about this that they established this lectureship, and we honor him every year with this inaugural lectureship. We believe that Dr. Towery would have been pleased about what his friends and colleagues set up for him in his passing. And the other important part of this is that one of his friends of many years from Vanderbilt, Grant Little, succeeded him as chief of endocrinology at Vanderbilt, was chosen as his first lecturer, and probably contributed to this lectureship series too. And with that, I'm going to let Sri introduce our elite speaker today, Dr. Shalender Bhasin, who will talk to us about testosterone and management as we age. Sri?
Thank you, Dr. Kruger, and welcome to Dr. Bhasin. We are very pleased to have Dr. Shalender Bhasin be our speaker for the 2022 Beverly Todd Towery lecture, which started 40 years ago. Dr. Bhasin is currently a professor of medicine at Harvard Medical School. He is the director of the Claude Pepper Older Americans Independence Center, director of the Brigham Research Assay Core Laboratory, and the director of the research program in men's health, aging and metabolism, co-director of the Center for Transgender Health at Brigham Women's Hospital. Dr. Bhasin is a graduate of All India Institute of Medical Sciences in New Delhi, where he graduated with distinction. He completed his residency training at Northwestern and his fellowship training at UCLA under Dr. Ron Swerdloff, one of the leading figures in the field of androgen studies. He joined faculty at UCLA and stayed there for almost 20 years, becoming a full professor. Later was chief of endocrinology at Boston University, and moved to Harvard Medical School in 2013, where he has been professor of medicine and has been at Brigham and Women's Hospital. He's an outstanding clinician, educator, and scientist. He has served as the chair of the Clinical Guidelines Subcommittee of the Endocrine Society, member of the Council of the Endocrine Society, and has been the chair of the Exam Writing Committee for Endocrinology and Metabolism at the American Board of Internal Medicine. He's also on the board of directors of the American Board of Internal Medicine. He has received the Outstanding Clinical Investigator Award of the Endocrine Society. He has well over 300 publications, and his research has been continually funded by the NIH and several other federal granting agencies. He has 13 active NIH grants at this time. His research focuses on promoting anabolic therapies, androgen biology, clinical trials, testosterone, and metabolism in aging. He is widely sought after to speak on several of these topics. In addition to serving on NIH study sections, he's also a member of the National Advisory Council on Aging at the National Institute of Aging. We welcome him to present this lecture today. Thank you.
Thank you, Sherry. Good morning, everybody. And I want to thank Drs. Kruger and Moshkandan for inviting me to deliver the 2022 Beverly Todd Towery lecture. I'm particularly honored and humbled to be giving this talk because of the important leadership role that Dr. Towery played in the growth of the Department of Medicine at University of Louisville. I hadn't realized that the department has a long history going back to 1837 during the Andrew Jackson administration. So it's a particular honor, and I thank you. Here are my disclosures. In particular, I'm not speaking on behalf of the American Board of Internal Medicine or the Endocrine Society or the institutions with which I am affiliated. For much of human history, societal ideas about human sexuality, particularly men's sexuality, have been guided by religious dogma and folklore. And much of this religious dogma was egregiously wrong, and it imposed enormous cruelty upon human beings. Much of it changed towards the end of the last century. Two pivotal events contributed to a major shift in our thinking about men's health and their genitourinary problems, and brought men's sexual health and aging out of the closet into the mainstream of internal medicine. These two events included the discovery of Viagra and direct-to-consumer marketing of testosterone products. In 1997, the Food and Drug Administration in the U.S. approved Viagra for the treatment of erectile dysfunction. The appearance of the then Vice President Robert Dole in Viagra ads brought the ED into the mainstream of our conversation, into the lexicon of dinner time discussions. And it also enabled men and their partners to speak to their doctors about problems related to their sexual and genitourinary problems. In the summer of 2000, Androgel, a transdermal testosterone gel, was approved by the Food and Drug Administration. Very aggressive and innovative direct-to-consumer marketing advertisements, initially by Solvay and then by AbbVie and other companies, led to an exponential growth in the sales of prescription testosterone products, which increased from around 18 million in 1988 to 100 million in the year 2000 to over 2.3 billion in 2013. And after a short decline in testosterone sales between 2013 and 2016, following the issuance of FDA's advisory on potential cardiovascular risk of testosterone sales in the country have resumed their upward climb. To be sure, testosterone as a prescription drug has been approved since the 1940s in the US. In fact, testosterone was one of the first prescription hormone product to be approved in the US. So why is testosterone treatment of older men with age-related decline so controversial, while testosterone is an FDA-approved product? The reason for this is that prior to the advent of radioimmunoassays, circa 1960s, 1970s, In men with most of the men who were diagnosed with hypogonadism had severe hypogonadism. The diagnosis in these men before we were able to measure testosterone precisely using immunoassays was based upon clinical findings of loss of secondary sex characteristics, infertility, breast enlargement, and small testes. So the diagnosis was clinically apparent, and testosterone treatment of these men with severe hypogonadism induced visible evidence of improvement in terms of induction of pubertal development, restoration of secondary sex characteristics, and restoration of sexual function. So both the diagnosis as well as the benefits were clinically apparent. Move forward 30 years. Today, 80% of testosterone prescriptions are written for men 40 to 74 years of age, in whom there is very substantial overlap between symptoms of testosterone deficiency and age-related conditions and symptoms. Most of these men have mildly low or borderline testosterone levels, and they have few overt signs of testosterone deficiency. And in these middle-aged and older men with very mild or borderline low testosterone levels, neither the long-term efficacy nor the long-term safety of testosterone treatment has been established. So it is in this context that I'll discuss the scientific rationale for testosterone treatment in older men with age-related decline in testosterone levels. I'll review the findings from recent large randomized clinical trials on the benefits and risks of testosterone treatment. And then I'll offer a synthesis and some personal reflections on how we might use the available information from recent large randomized trials in our clinical practice. There is agreement from nearly 40 or 50 cross-sectional epidemiologic studies and over a dozen longitudinal studies that total testosterone concentrations are lower in older men than in younger men, and they decline with advancing age, starting shortly after puberty. These are our own data using LC-10 mass spectrometry in 3 epidemiologic studies from Ingham Heart Study, European Male Aging Study, and a study of male fractures. And you can see that total testosterone levels decline with advancing age. And using more rigorous, accurate LC-MS/MS assays, we have found that the prevalence of middle-aged and older men with low testosterone levels is about 10% on average across epidemiologic studies. In the European Male Aging Study, the prevalence of total testosterone levels less than 240 nanogram per deciliter plus sexual symptoms was 3.2% for men 60 to 69 years of age, and increased with advancing age to about 5% in men 70 to 79 years of age. In epidemiologic studies, testosterone levels are positively associated with measures of sexual desire and sexual activity, with muscle mass, maximal voluntary strength and physical function, and areal as well as volumetric bone density and bone quality. Testosterone levels are negatively associated with whole body and visceral adiposity, prevalence of metabolic syndrome, type 2 diabetes, coronary artery disease, frailty, mobility limitation, falls and fracture risk, late life low-grade persistent depressive disorder, which was previously known as dysthymia. And there is some association with the risk of dementia and fibrillar amyloid beta deposits. Lower testosterone levels are also associated with higher all-cause mortality and telomerase length. So this is a meta-analysis that was published by Andre Araujo here in Boston. And low testosterone levels were associated with increased risk of all-cause as well as cardiovascular mortality. So testosterone, it's possible, may be a marker of poor health. which may contribute to increased risk of mortality, and it may also lead to lower testosterone levels. So reverse causality cannot be disproved. Fortunately, over the last 10 years, a large number of well-conducted, many NIA-funded, randomized controlled trials have taught us a great deal about the efficacy of testosterone treatment. I'll, in particular, talk about the testosterone trials, the T trials, which were a set of 7 NIA-funded linked trials, which have taught us a great deal about the efficacy of testosterone. T4DM trial was a trial to determine if testosterone treatment can prevent progression to or reverse type 2 diabetes. And many of the other trials in middle-aged and older men with low or low normal testosterone levels were focused primarily on muscle performance and physical function, and secondarily looked at a number of other outcomes as well. So let's first look at the efficacy of testosterone replacement in improving sexual function. The testosterone trials, or the T trials, were a set of 7 placebo-controlled, double-blind coordinated trials. There were 3 primary trials: the sexual function trial, the physical function trial, and vitality trial. These trials aim to determine the efficacy of testosterone in improving sexual function, physical function, and vitality or fatigue in older men who had unequivocally low testosterone levels and low libido, mobility limitation, and or low vitality. The eligible subjects had to have an average of 2 fasting early morning total testosterone levels measured by LC-MS less than 275 nanogram per deciliter, plus 1 of either low libido, mobility limitation, or low vitality or fatigue. Intervention duration was 1 year, and the eligible participants were allocated by minimization to either placebo or testosterone gel, and the dose of testosterone gel was adjusted based upon on-treatment testosterone levels using a complicated blinding strategy to maintain testosterone levels within the target range of 400 and 700 nanogram per deciliter. So what do we know about testosterone effects on humans, on male sexual function? Humans have known since antiquity that you can take away the vigor and sexual vitality of men by removing their testes. In the 1960s and 1970s, a pioneer, Julian Davidson at Stanford University, evaluated the role of testosterone in spontaneous as well as induced erections. Davidson compared eugonadal men with hypogonadal men, and he found that hypogonadal men had lower self-reported sexual activity and thoughts and fewer spontaneous and nighttime erections. But when he showed these hypogonadal men visually erotic materials such as a Playboy magazine or an X-rated video, these hypogonadal men were able to achieve normal erections. Then he put these hypogonadal men on testosterone replacement therapy, and testosterone treatment increased sexual feelings and thoughts and overall sexual activity and the number of spontaneous and nighttime erections. But testosterone treatment did not change erectile response to visual erotic stimuli. So Julian Davidson's pioneering studies led to the prevalent dogma that spontaneous but not stimulus-induced erections are testosterone dependent, and that testosterone stimulates sexual thoughts and feelings and attentiveness to erotic cues and stimuli, attributes that we broadly lump together under the term libido. But there's additional evidence from our and other studies that suggests that testosterone also acts on nitric oxide synthase and is necessary for achieving optimal penile rigidity. In the testosterone trial, testosterone treatment of men who had low testosterone levels and low libido was associated with greater improvements in overall sexual activities, as shown here, relative to placebo, increase in sexual desire, and improvements in erectile function and satisfaction with sexual performance. TEAP trial was a randomized placebo-controlled trial of testosterone treatment for 3 years. The primary aim of the TEAP trial was to determine the effect of testosterone treatment on atherosclerosis progression in middle-aged and older men, 60 to 75 years of age, who had total testosterone less than 350 and low free testosterone levels. These men were treated with 1% testosterone gel or placebo gel for a period of 3 years, and you can see that testosterone treatment did not improve any aspects of sexual function in these men who had no sexual symptoms at baseline and who had normal testosterone levels. So from the T trials, we've learned that testosterone improves overall sexual activity, sexual desire, and erectile function in men with low testosterone levels and decreased libido. And the TEAM trial has taught us that testosterone does not improve any aspect of sexual function in men who have normal testosterone levels and have no sexual symptoms at baseline. In other studies, testosterone has not been shown to improve ejaculatory function in men who have ejaculatory dysfunction. Also, the effect of testosterone on erectile function in men who are using phosphodiesterase inhibitors such as Viagra still remain a little bit unclear. Testosterone increases muscle mass, maximal voluntary strength and power, and several measures of physical function, particularly those measures of physical function that are associated with muscle strength. In the TEAM trial that I just described before, testosterone treatment was associated with greater gains in lean body mass, leg press power, and stair climbing power, a measure of function that is very critically associated with quadriceps muscle strength. Testosterone's anabolic effects in increasing muscle mass and strength are related to testosterone dose and on-treatment testosterone concentrations. So in these randomized trials, we treated healthy young and healthy older men with graded doses of testosterone after suppressing their endogenous testosterone production by administration of a long-acting GnRH agonist. As you can see, testosterone administration at these graded doses ranging from 25 milligram per week to clearly supraphysiologic doses such as 125, 300, and 600 milligram per week dose was associated with dose-dependent increases in leg press strength shown here and lean body mass and lower extremity muscle mass, data that are not shown in this slide. So testosterone's effects on muscle mass and strength are dose-related. The increase in muscle mass during testosterone treatment is due to hypertrophy of both type 1 and type 2 skeletal muscle fibers, as shown here. Testosterone increases the number of muscle progenitor cells, which are referred to as satellite cells. So the increase in satellite cell contributes to muscle fiber hypertrophy. So how does testosterone increase the number of muscle progenitor cells? Our studies over the last 15 years have shown that testosterone regulates the differentiation of multipotent muscle progenitor cells into the myogenic lineage and inhibits their differentiation into the adipogenic lineage. In addition, testosterone increases the entry of satellite cells into the cell cycle and may increase the number of myoblasts. So this leads to increase in muscle mass and a reciprocal decrease in fat mass. So how does testosterone regulate the differentiation of muscle progenitor cells? Again, our studies going back over the last 15 years have shown that testosterone binds to androgen receptor, and ligand binding leads to a conformational change in androgen receptor, which enables it to recruit additional coactivators. One of these coactivators is beta-catenin. In the process, it stabilizes beta-catenin, and this complex then it recruits additional chaperone proteins and translocates into the nucleus, where it binds additional transcription factors and activates the transcription of a number of Wnt target genes, including follistatin. Follistatin plays a very important role in mediating testosterone effects, in regulating mesenchymal progenitor cell differentiation. Follistatin blocks the action of a number of TGF-beta family members, including myostatin and activin, and that's how it exerts its anabolic effects on the muscle. Our studies have shown that testosterone replacement in older men for 3 years also attenuates the age-related decline in aerobic capacity measured as VO2 peak in cardiopulmonary testing. The increase in VO2 peak is related to the change in hemoglobin. Testosterone increases hemoglobin levels, and the increase in hemoglobin level increases VO2 peak and aerobic capacity. And that explains why endurance athletes such as Lance Armstrong, Floyd Landis, and others abuse androgens to increase their aerobic capacity. In the T trials, we looked at the effect of testosterone on self-reported mobility as well as on 6-minute walking distance. Testosterone consistently improved self-reported walking ability. The men who were allocated to testosterone arm of the trial were more likely to report improvements in their walking ability than men who were assigned to the placebo arm. Testosterone also modestly improved the 6-minute walking distance in all T trial participants, although the improvements in gait speed was related to T levels and changes in hemoglobin levels. These improvements were modest. How does testosterone affect metabolic health? In epidemiologic studies, low testosterone levels are associated with increased risk of type 2 diabetes and metabolic syndrome. But this association is stronger between SHBG levels and the risk of diabetes and metabolic syndrome than the association of free testosterone with metabolic syndrome and diabetes risk. Mendelian randomization studies of the UK Biobank data have shown that this association between genetically determined testosterone levels and the risk of diabetes is sexually dimorphic. In men, genetically determined higher testosterone levels are associated with lower risk of type 2 diabetes. But in women, higher genetically determined testosterone levels are associated with increased risk of type 2 diabetes and polycystic ovary syndrome. In randomized trials, testosterone treatment reduces whole body appendicular and visceral fat, but has minimal effects on lipids in replacement doses. But in many of the studies, including the T trials, we didn't find consistent effects of testosterone treatment on hemoglobin A1C or measures of glycemic control. The T4DM trial, which was conducted at multiple centers in Australia and was funded by MRC Australia, is a randomized clinical trial that determined the effect of testosterone treatment for 2 years on progression to and reversal of type 2 diabetes. The participants were middle-aged men, 50 to 74 years of age, who were at increased risk of type 2 diabetes or had been newly diagnosed to have type 2 diabetes but were not yet on treatment. These men were then randomly allocated to receive a lifestyle intervention, which was referral to Weight Watchers, plus testosterone versus lifestyle intervention alone for a period of 2 years. The primary outcome was proportion of men with type 2 diabetes diagnosed as 2-hour oral glucose tolerance test glucose greater than 200 milligram per deciliter and mean change in 2-hour oral glucose tolerance test glucose concentrations. So what did this trial find? The trial found that testosterone treatment was associated with a lower proportion of men with 2-hour glucose greater than 200 milligram per deciliter at 2 years compared to placebo. And testosterone treatment was associated with slightly greater reduction in 2-hour glucose than that which was associated with placebo treatment. The main problem with the T4DM trial is that these men were not hypogonadal. They didn't meet the Endocrine Society's definition of hypogonadism. They were selected based on a testosterone level less than 402 nanogram per deciliter. Testosterone has been consistently shown to improve both areal as well as volumetric bone mineral density, both in the spine and in the hip. These are data from the T trials. Testosterone treatment increased both areal and volumetric bone density in the T trials relative to placebo, as well as estimated bone strength. And these improvements were seen both in the spine and the hip, and the improvements were greater in the trabecular bone than in the peripheral bone. And these improvements were comparable to the improvements that have been associated with many approved osteoporosis drugs. The relationship of testosterone and depressive symptoms has remained unclear. Middle-aged and older hypogonadal men often report low mood, but testosterone levels are not associated with major clinical depression. In epidemiologic studies, low testosterone levels have previously been associated with low-grade, late-onset, persistent depressive disorder, which in previous DSM versions was referred to as dysthymia. There are very few large, well-controlled trials, but 2 small trials have shown that in men with dysthymia, testosterone treatment improves depressive symptoms, but other randomized trials have not shown improvements in major clinical depression or in response to antidepressants in patients with major clinical depression. Overall, meta-analyses have reported small improvements in depressive symptoms in men assigned to testosterone arm of randomized trials. Testosterone consistently increases hemoglobin and hematocrit and red cell count. The increases in red cell counts are because of testosterone working through several different mechanisms. Our studies have shown that testosterone has direct effect on hematopoietic progenitor cells, resulting in an increase in the hematopoietic progenitors that are committed to the common myeloid progenitor series, so that it increases the counts of not just red blood cells in the peripheral blood, but also other cell lines that are derived from common myeloid progenitors in the bone marrow, including neutrophils, monocytes, and platelets. In the T trial, a greater proportion of men assigned to the testosterone arm corrected their anemia and showed an increase in their hemoglobin of more than 1 gram per deciliter. Testosterone treatment in randomized trial has not been shown to improve the scores in paper pencil questionnaires to determine quality of life, such as the short form 36. But consistently, testosterone has been shown to improve physical function domain. And T trials data confirmed this finding. So people who are randomized to testosterone arm will report that they perceive that their physical function has improved. Surprisingly, in spite of testosterone's known effects in increasing mitochondrial biogenesis, increasing muscle mass and strength and aerobic capacity, in T trials we didn't find a clinically meaningful improvement in measure of fatigue using FACIT-1 scale. But in other trials which have used more psychometrically robust measures of fatigue that are specific to hypogonadism, others have reported increases in energy using a scale that was specific to hypogonadism. In the T trial and in the team trial, we didn't find improvements in measures of cognition. But these men did not have any cognitive deficit. So in men who do not have cognitive deficit, testosterone does not improve measures of cognitive function. There's quite a bit of promising preclinical data that suggests that in preclinical models of Alzheimer's disease, testosterone replacement can prevent development of Alzheimer's disease pathology in these preclinical models. And there are data from the Baltimore Longitudinal Study of Aging, BLSA, that suggest that low testosterone levels are prospectively associated with increased risk of Alzheimer's disease diagnosis 10 years later. What about testosterone safety? In randomized trials, overall, there's been a low frequency of adverse events as well as serious adverse events associated with testosterone treatment. But these men in randomized trials also were very carefully selected, and men with significant comorbid conditions or prostate disease or cardiovascular risk were excluded from these trials. Erythrocytosis is the most frequent adverse event in clinical practice as well as in randomized trials. And I'll talk a little more about the risk of prostate disease, but it's clear that testosterone does not seem to increase the risk of prostate cancer, but increases the risk of detection of subclinical prostate disease. There's no significant change in lower urinary tract symptoms in men who do not have severe lower urinary tract symptoms at baseline, and these data are consistent across trials. Testosterone suppresses spermatogenesis due to suppression of gonadotropins and will induce infertility. So testosterone treatment should not be given to men who are planning to have children. In randomized trials, testosterone treatment has been associated with very low rates of gynecomastia. There have been very few thromboembolic events and very low rates of newly diagnosed sleep apnea during testosterone treatment. None of the trials to date has been large enough nor long enough to evaluate effects on major adverse cardiovascular events or on prostate cancer risk. Testosterone treatment is associated with significantly higher frequency of erythrocytosis compared to placebo. The increases in hemoglobin and hematocrit are related to testosterone dose and circulating testosterone levels, and older men exhibit greater increases in hemoglobin and hematocrit than younger men. A common issue that arises in clinical practice is that if the hematocrit rises, how should we manage these people with erythrocytosis? Because the increases in hemoglobin and hematocrit are associated with circulating testosterone levels, reducing the dose can reduce the increase in hemoglobin and hematocrit. If hematocrit rises above 54%, testosterone dose should be withheld until hematocrit has fallen to a safe level, and it may take several weeks, 8 to 12 weeks. These men should be evaluated for other causes of erythrocytosis, and then testosterone can be restarted at a lower dose. A critical issue is at what level of hematocrit should we start worrying and stop testosterone treatment? Even though the expert panel of the Endocrine Society decreed that 54% is a level where we should get concerned. This is not as clear from the literature. As hematocrit rises from low to normal range, plasma viscosity increases, the blood viscosity increases, and as hematocrit rises above 50%, you can see that the plasma viscosity increases exponentially. As hematocrit levels increase from 20 to 40%, it is associated with increase in blood flow to the tissues, as well as net oxygen delivery to the tissue. But somewhere between 45 and 55 or 60%, there's an inflection point where the net blood flow to the tissue and the net oxygen delivery begins to decline. And we don't quite know where precisely this number is. We think it's somewhere north of 50%, and that's why the cutoff of 54%. But in men with pre-existing significant atherosclerotic disease, such as men with end-stage renal disease or men on hemodialysis, this could be at a substantially lower hematocrit. And this is reflected in data showing that increases in hematocrit above 36% in men on hemodialysis who are receiving erythropoietin is associated with increased cardiovascular risk. Androgen receptor signaling plays an important role in the biology of prostate cancer. But there's no clear evidence that testosterone treatment increases prostate cancer risk. Testosterone treatment does not worsen lower urinary tract symptoms. But hypogonadal men have lower PSA levels than eugonadal men, and testosterone treatment increases PSA, and because increases in PSA can lead to prostate biopsy, in earlier randomized testosterone trials, there were a greater number of prostate biopsies in men randomized to testosterone arm. In fact, there were 20 times more biopsies done in men in the testosterone arm than in the placebo arm. And increased prostate biopsies in 60 or 70-year-old men will lead to detection of increased number of subclinical prostate cancers. A third of 70-year-old men will have subclinical cancers in their prostate. So the risk of testosterone treatment isn't that it causes prostate cancer, but that it increases the risk of prostate biopsy and thereby increases the risk of detection of a subclinical prostate cancer. Mendelian randomization studies genetically determined bioavailable testosterone levels were positively associated with lifetime risk of prostate cancer. So it's possible that long-term testosterone treatment may increase the lifetime risk of prostate cancer, but in the randomized trials, the prostate cancer events have been very, very few, and there's just insufficient data to determine whether testosterone increases prostate cancer risk. So an important clinical issue that arises in clinical practice is that when you start people on testosterone, their PSA levels will rise. And the question is, what level of PSA increase is acceptable? And what level of PSA increase should lead to urological referral for consideration of prostate biopsy? Our studies suggest that the average increase in PSA is about 0.3 nanogram per ml after starting testosterone treatment in young hypogonadal men and 0.44 nanogram per ml in healthy older hypogonadal men who do not have prostate cancer. Increments of greater than 1.4 nanogram per ml are uncommon in men without prostate cancer. In epidemiologic studies, 90% confidence interval of PSA elevation or PSA change between tests performed 3 to 6 months apart is 1.4 nanogram per ml. So based on these data, the expert panel of the Endocrine Society suggests that an increment of greater than 1.4 nanogram per ml in the first year after starting testosterone treatment, or a PSA, any PSA level greater than 4 nanogram per ml, should lead to urological evaluation. An important point to remember is that PSA elevations, transient PSA elevations, are exceedingly common. And some of these are due to assay variation, and some of these PSA elevations are due to non-cancer causes that are not well understood. In the T trials, for instance, we found that when the PSA levels were repeated, we found that half of the PSA elevations disappeared. And even among men who were referred for urological evaluation and had to wait 3 or 4 months, and the urologist then repeated PSA, another half of these men had normal PSA levels. So I think it's really important before getting excited about PSA elevations to repeat a PSA within 4 to 6 weeks. There's been a lot of controversy about the relation of testosterone treatment with cardiovascular risk. There are a number of meta-analyses that have been published, and a lot of pharmacovigilance studies have been published. But the results of these epidemiologic studies and pharmacovigilance studies, based on retrospective review of electronic medical record data, they are essentially inconclusive because of inherent problems with the way these data have been collected. And no randomized trial has been large enough or long enough to determine whether testosterone treatment increases the risk of major adverse cardiovascular events. So there is insufficient randomized data to ascertain this issue. Similarly, we don't have enough data to determine whether testosterone increases the risk of thromboembolic events. The number of thromboembolic events has been very small in randomized trials, and most of the thrombotic events that have been reported in literature have occurred in people who have a hypercoagulable state, such as a mutation in protein C, protein S, antithrombin 3, etc. In the TEAM trial, we determined the effect of 3 years of testosterone treatment on atherosclerosis progression, measured using common carotid artery intima media thickness or using coronary artery calcium measurements by MDCT. And you can see that the rate of atherosclerosis progression did not differ between placebo and testosterone arms. In the T trials, we did coronary CT angiography, and we found that men randomized to testosterone arm had greater rate of increase in soft, non-calcified plaque. This increase was small, but there were also some baseline differences between the two arms. So the significance of this finding in terms of increase in soft, non-calcified plaque both needs confirmation and remains a little bit unclear at the present time. Fortunately, a large cardiovascular safety trial called the TRAVERSE trial is currently in progress. The TRAVERSE trial is the largest randomized clinical trial of testosterone replacement therapy in middle-aged and older hypogonadal men, 45 to 80 years of age, who are at increased risk of cardiovascular events. This trial has completed enrollment as of the 1st of this month. I'm happy to tell you. It has enrolled 250 men, and treatment duration was up to 5 years. And primary outcome of this trial is major adverse cardiovascular events. But the TRAVERSE trial will teach us a lot about prostate events, invasive prostate procedures for BPH, clinical fractures, remission of dysthymia, progression from pre-diabetes to diabetes, or remission of diabetes, and remission of anemia. Because of the concern about prostate and cardiovascular event, we've invested a great deal of effort, and many pharmaceutical companies have as well, in developing strategies to achieve a higher level of selectivity, tissue selectivity of testosterone action to increase the benefit to risk ratio. And the most advanced of these efforts is the development of a large number of oral, non-steroidal, selective androgen receptor modulators, or SARMs, which are androgen receptor ligands that display tissue selective activation of AR signaling. We've also looked at the possibility of using testosterone plus 5-alpha reductase inhibitors such as finasteride or dutasteride and testosterone plus inhibitors of polyamine biosynthesis to spare the prostate. And we are also developing nanoparticle formulations to achieve tissue selective delivery of testosterone. So in summary, I think it's really important to distinguish classical hypogonadism due to known diseases of the testis, pituitary, and the hypothalamus. In young men with classical hypogonadism due to known diseases of the testis, pituitary, and the hypothalamus, testosterone treatment improves a number of symptoms, particularly sexual symptoms, with very low frequency of adverse events. And the benefit to risk ratio in these men with confirmed hypogonadism is favorable. In older men with age-related decline, we've learned from recent randomized trials, but particularly key trials, that testosterone improves some aspects of androgen-dependent functions, such as sexual function, anemia, volumetric, as well as areal bone density and quality, muscle mass, strength, and some measures of physical function. But the long-term benefits in improving hard outcomes such as fractures, physical disability, falls, progression to diabetes, or correction of depressive symptoms still remain unknown. And long-term risks of prostate and cardiovascular events also remain unknown. So how should we manage patients, so many of them who are seeking help from their clinicians for age-related decline in testosterone levels? The expert panel of the Endocrine Society recommended against routinely prescribing testosterone treatment to all older men with low testosterone levels. But the panel also recognized that there is the potential for some benefits, although there is some uncertainty of the long-term harm. And so the panel cautiously suggested that in older men who have symptoms or conditions suggestive of testosterone deficiency, such as low libido or unexplained anemia and consistently low testosterone concentrations, that clinicians offer testosterone treatment on an individualized basis after explicit discussion of the potential risks and benefits. Now, a very pragmatic, middle-of-the-ground approach that all of us as astute clinicians practice on every day in our clinics. Here is a middle-of-the-ground approach that I use in my practice. And it's based upon the simple idea, which is the foundation of our higher call to being a physician, that our role as physician is to mitigate people's suffering and to do no harm. So it's really important to consider these when you're seeing a patient who's seeking your consultation to mitigate suffering related to low testosterone levels. It's really important to establish that the patient has testosterone deficiency and to recognize the high level of diagnostic imprecision. Weigh the burden of symptoms and condition against the known benefits and the uncertainty of long-term harm, recognizing that you can't make an asymptomatic person feel better, and there's also the potential of harm. Ascertain conditions that might increase the risk of harm, history of prostate cancer, or previous history of deep vein thrombosis, or a recent myocardial infarction. Establish a standardized monitoring plan and share the burden of decision-making with the patient, because only the patients can tell us the burden of symptoms, and only they can value whether they are willing to bear the burden of long-term monitoring, the cost of treatment, and the uncertainty of long-term harm. And this approach can optimize the benefit to risk ratio and also align your values and your views with those of the patient. So in closing, I want to acknowledge my debt to the many colleagues and collaborators who over the last 4 decades have contributed to the data for which I've taken credit today. And I'm very indebted to all of these friends and collaborators. And thank you again for this great honor to enable me to give this lecture. Thank you.
Thank
Dr.
you so
Bhasin,
much.
that was
Oh, go ahead, Dr. Kruger.
fantastic. That was fantastic. I think we learned a lot, and I'm sure we have a couple of questions. We have a couple of minutes. I have a burning question. Sri, you probably do too. But as you know, women who are postmenopausal also take either DHEA or testosterone for mental clarity, for libido, and for muscle mass. Are there similar randomized controlled trials ongoing about the safety of these supplements in women?
A large number of very well conducted large clinical trials were conducted about 10, 15 years ago and published in reputable journals. And they all showed consistent improvements, but small improvements in sexual desire and overall sexual activity in menopausal women with and without. Some of these studies included women who were getting estrogen replacement therapy and some did not. And testosterone showed efficacy in improving sexual desire and overall sexual activity. The FDA did not approve testosterone patch because of the concern of the FDA advisory board about long-term cardiovascular safety in women. But in Europe, the patch was approved, and many gynecologists continue to use testosterone off-label for treatment of female sexual dysfunction.
Thank you. Well, one of the questions that I had was, we have patients who we're treating them for their symptoms, and if the symptoms are persistent and the testosterone goes up to 500 or so, would you tend to increase the dose, or how do you relate the dosing with the symptoms versus the level?
So that's really an important point, and I want to highlight 2 issues. One is that our studies suggest that 50% of hypogonadal men who were started on the approved starting dose of any of the testosterone products, particularly transdermal products, will have subtherapeutic levels. And therefore, it's not surprising that 50% of men never refill their first prescription. So within 3 months of getting a prescription, 50% of men will never refill their prescription. And I think part of it is due to the subtherapeutic levels. And at the end of a year, 3/4 of the men will have stopped taking testosterone. So point number 1, really important to monitor testosterone levels. 5 to 10% of people on the starting dose will have supraphysiologic levels, and their dose needs to be reduced. And 50% will have subtherapeutic levels, and their dose needs to be adjusted. I generally aim to get people into the middle of the normal range, and because of variation in testosterone levels on transdermal gels, it's I aim to get it between 400 and 700.
Thank you. So due to shortage of time, I'll just go through one of the questions that's here, which is kind of topical in a sense. Does COVID infection increase hypercoagulability risk in testosterone replacement therapy?
So we don't know. I've given it a lot of thought. Any acute illness will lower testosterone levels. And also, when patients are hospitalized with an acute illness, sepsis of any kind, there's increased risk of hypercoagulability. So I generally tell people whether they are hospitalized because of unexpected infection or other illness, or if they have an elective admission because of surgical procedure, to withhold testosterone treatment for about a week prior to the procedure and to not restart it until they are ambulatory, typically a couple of weeks after they've gotten out of the hospital. So that's sort of a rule of thumb, because nearly all the data suggests that people who are hypercoagulable, they are nearly 90% of the case reports of venous or arterial thrombosis with testosterone treatment have been in men who had a hypercoagulable state.
Okay. Thank you very much. I think we're almost out of time. So thank you very much for the wonderful talk, and also for yesterday's talk and meeting with our fellows and with us. So sure see you again at the Endocrine Society and other meetings. Yeah.
Yes, thank you so much, Dr. Kruger and Dr. Mokshandan.
You're welcome. You're going to receive a bat, because we're all about tradition here. So you're going to receive a monogram Louisville bat in the mail. And it was a former chair's desire that all our outside speakers can advertise for Louisville in their offices. So thank you very much. And
Yes.
we really appreciate it.
Yeah, thank you so much, Christine.
Bye-bye.
Bye-bye.
Thank you.
Thank you.
Thank you, Dr. Bhasin. Thank you, Dr.